And we are live.
Good evening, everyone. Welcome to our Aim at Skin Cancer Symposium. We're so glad that you're here. We know that you've just gotten your notification that we are live and everyone is loading on. So we'll wait another 10 or 15 seconds to give people an opportunity to load into the symposium, and then we'll begin. So once again, good evening. I'm Ann Garst-Taylor. I'm the Director of Community Engagement for AIM at Melanoma, which is the parent company for AIM at Skin Cancer. Our foundation was launched in January of this year, and this is the second of our AIM at Skin Cancer symposiums. I'll have an opportunity to tell you more about our foundation later, but of course, I want to thank OHSU for co-hosting this evening's symposium. I want to thank Dr. Yu for serving as our fearless leader and moderator, and then I want to thank our panelists for all of their presentations. I know that you will have lots of questions for them, and there will be a question and answer period at the end of the symposium. If you are viewing via Zoom, then if you look to the bottom of your screen, you'll see a tab down there that says Q&A. If you'll put your questions in there, then Dr. Yu can see them. And if you are viewing this evening's symposium via AIM at Melanoma on our Facebook Live page or AIM at Skin Cancer on our Facebook Live page, then just put your questions in the comments and then we'll transfer them to the Q&A for Dr. Yu. And so with that, I'll pass the baton to Dr. Yu so he can open up our symposiums. Thank you, Dr. Yu.
Thank you so much, Anne. Thank you for inviting us to be part of this and co-hosting this wonderful symposium. I'll get started by introducing our first speaker, Dr. Angela Jiang. She's an assistant professor here at OHSU and is specially trained in both dermatology and dermatopathology. This means that she has special expertise in the diagnosis of skin cancer, and her diagnosis and recommendations often guide the surgical management plan. Today, she'll be giving us an introduction to non-melanoma skin cancers. Thank you, Dr. Jiang, for joining us today.
Thank you for having me and for inviting me and for putting on this amazing symposium. So I'm gonna start. And so today I'll be talking about an introduction to non-melanoma skin cancers. And so non-melanoma skin cancers are basically a broad category of skin cancers. And basically it's all the other skin cancers that are not melanoma. And the most common ones being basal cell skin cancer and squamous cell carcinoma. But this category can also include other rare skin cancers that we won't be going super in detail in today. Unlike melanoma, these skin cancers aren't under official cancer registries. So a lot of the statistics are often estimated based off of insurance data. But even so, we do know that non-melanoma skin cancers are far more common than melanoma. And it's estimated that 1 in 5 Americans will develop a skin cancer in their lifetime. So I'll start off by talking a little bit more about a basal cell carcinoma, which is the most common type of skin cancer. And about 2.5 to 3 million Americans are diagnosed with basal cell carcinoma every year. And to put it into perspective, there are about 1 million new diagnoses of melanoma every year. Basal cells are fortunately very slow growing, so they can grow deeper in the skin, but it's very uncommon for them to enter the lymph nodes or into the blood vessels. But sometimes if they are allowed to grow, they can penetrate nerves and bones and cause damage or disfigurement. Basal cell skin cancers usually come up because of long-term sun exposure. And then there are some genetic syndromes that make people more likely to develop basal cell skin cancers. And basal cell carcinoma, it can have a wide variety of appearances like we see here. I picked a few representative photos. It can start off as a pearly, papule is what we often call them, but it can be this kind of pinkish patch, or it can sometimes look like a scar. And sometimes it can be kind of scary looking and almost look like it might be a melanoma with some of this kind of bluish gray look to it. And so seeing a dermatologist and kind of having an evaluation can be really helpful in these situations. Basal cell skin cancers, they most commonly are found on the head, neck, and arms, which are the most sun-exposed areas. Squamous cell skin cancers, or SCCs, these are the second most common type of skin cancer. And while there are 2.5 to 3 million new diagnoses of basal cell every year, there are about 200 to 400,000 new diagnoses of squamous cell every year. And similar to basal cell skin cancers, squamous cell carcinomas often develop from long-term sun exposure. They can also occur in areas with chronic wounds, and then we also can see them more often in patients who are immunosuppressed or have had an organ transplant. And squamous cell skin cancers have more of a potential to metastasize to lymph nodes, but it doesn't happen that often. It's about 1 to 5% of all squamous cells. And then they do have the potential to invade the nerves if they're allowed to grow too large. And these are some representative photos of squamous cell carcinomas. So it can look like a red firm bump, but it can also look like a scaly patch, or it can look like a sore that heals and then reopens. These also often happen on sun-exposed areas, and this photo is just to remind everyone to not forget to put sunscreen on your ears too. And then squamous cell carcinoma in situ is a subtype of squamous cell carcinoma, where the bad skin cells that kind of went awry, those are limited to the top layer of skin. And so when you go and get your skin checked by a dermatologist or another provider, not only do we look at all of your moles and compare them and look to make sure that nothing looks suspicious for a melanoma, we're also doing a skin check to make sure that there isn't anything that looks like a non-melanoma skin cancer. So when we do see something that looks suspicious, we rely on our clinical experience just from diagnosing a lot of skin cancers. But you may have also seen these handheld tools called dermatoscopes during skin checks. And basically a dermatoscope is a magnifying, like it has a magnifier in it, and then it also has a light that can polarize on the skin surface, so we can see certain features a little bit clearer than others. And a lot of dermatology providers will train with these so then we can recognize the patterns of both melanoma and non-melanoma skin cancers. And so, for example, with a dermatoscope, when we look at a pearly pink papule, we might see these really crisp blood vessels that look like tree trunks. And then we become even more suspicious that something might be a basal cell skin cancer. But the only way to know for sure if something is a skin cancer or not is to perform a biopsy. So a biopsy is when we numb the skin with a local anesthetic injection, and then we'll use a blade to kind of remove the bump or the area that we're worried about so that we can look further under the microscope and know what's going on. And so when we perform a biopsy, the tissue that we remove goes into a formalin jar. And then that jar gets transported to a lab. And at the lab, they remove the piece of skin in the jar and they embed it into a block of wax called a paraffin block. And then our histotechnologists will then cut very, very thin slices from the paraffin block and put them on a glass slide. And so that's what pathologists can look at. And so pathologists are doctors who can diagnose things under the microscope and also can do a variety of other tasks. And dermatopathologists like myself I am a dermatologist, but I also did an additional year of training just reading these glass slides and learning how to diagnose different types of skin diseases under the microscope. But pathologists also can do another year of training and learn to do the same. And so in dermatopathology, it's either dermatologists or pathologists, but we can diagnose other skin conditions under the microscope. And so when I look at one of these glass slides under the microscope, I might see something that looks like this. So if we look at, this is basically what, when we remove the skin, this is the top layer of skin. And then under the skin, we see these like very large purple bumps, and these should not be here. And this is what makes up a basal cell skin cancer. And then in contrast, this is something I might see that would be a squamous cell skin cancer. And these are slides that I've received kind of recently. But this has kind of like a pink glassy look to it and makes us more suspicious of a squamous cell skin cancer. And so when I diagnose these, then I release a report, which is something that both the doctors and patients can receive through their medical record. And it will have a diagnosis like basal cell carcinoma. I might describe the type and then tell you, and this is mainly information for the doctor or the dermatologist that you saw about whether or not the tumor goes to the areas that they sampled. So I tried to go over kind of like the basics of skin cancers and talked about basal cell and squamous cell skin cancer. And then also how we make the diagnosis clinically, but more so under the microscope. But thank you for having me.
Thanks, Dr. Jiang. That was awesome and a great overview of diagnosis all the way from seeing it on the skin to taking the biopsy, getting the report, yeah, that was a really nice whole overview for everyone. I think we will probably reserve questions until the end. Remember, everyone, if you have questions, feel free to put them in the Q&A tab. Those questions can be anything from something that you've experienced to sort of more general questions. I am really happy to introduce our next speaker, who's going to talk about after the diagnosis that Dr. Jiang just talked about, what might happen to treat that skin cancer. Oftentimes the treatment for these skin cancers is surgery. Dr. Brian Carroll is a full professor at Case Western Reserve University. He's a Mohs micrographic surgeon and dermatologist, meaning that he cares for patients with skin cancer daily and is an expert in surgical treatment of high-risk tumors. He also does a lot of research focused on improving surgical methods for the comfort and safety of patients. He's made seminal contributions to the field in pain control and laboratory evaluation of tumors. Dr. Carroll's also a personal mentor to me and someone I regularly turn to for clinical advice and advice in general. So thank you, Dr. Carroll, for presenting today. Really excited to hear your thoughts on skin cancers.
Thank you, Wesley, and thank you, Anne and AIM at Skin Cancer, for inviting me tonight to talk about some of the questions that our patients have every day. So we're going to talk about the experience once you've gotten your biopsy. I have no disclosures, and I won't be talking about anything off-label tonight. So the preoperative consultation after a biopsy can happen before or during the day of your treatment. And as a physician, this emotion chart is usually what I'm thinking about as I'm meeting someone for the first time. I'm trying to figure out if they're scared or if they're unhappy. Rarely do they come in feeling confident and playful, but our goal is to move them from the uncomfortable emotions to the positive emotions. And it's our goal to check in to see what is most consuming the thoughts of our patients who've had a biopsy with the skin cancer diagnosis. And I like to divide these concerns of patients into four types of concerns. The first is comfort. Will they be comfortable during the surgery? Will they be comfortable after the surgery? Second, sometimes people are thinking only about the cancer. What does it mean for them as far as their next few hours with us with a treatment? What's going to be involved? But also, is this something that's going to be impacting their future? What is the full impact of the diagnosis of cancer? Next, some patients have their cosmetic concerns first and foremost, so they're most concerned about making sure that after the treatment, they look as beautiful as they did before. And last, we have people who have their activities of daily living and knowing whether or not they'll be able to go to the gym or whether they'll be able to walk their dogs tomorrow. Those are the things that drive their concerns. So I like to recommend to patients to think about their day of treatment like going to the spa. I know it's a bit of a stretch, But if you think about it's a day that you're going to make about yourself, and you're going to try to bring the things that you like to the day of treatment, whether it's books, music, a screen to watch video, really use the time of your treatment as something just to sort of turn off your other concerns and focus on yourself. Also want to know that different providers have different recommendations for what you need to do before. The majority of surgeons are going to be recommending that you make no changes to your daily medications. If you do have specific questions, that's something that you can call the office beforehand. Most commonly, people ask about their blood thinners. And most commonly, we surgeons tell patients not to change their blood thinners. For internal concerns, some internal surgeons make recommendations on blood thinners to stop them before surgery. But for the majority of cutaneous surgeries, we don't need to change blood thinners. Your day of surgery, very frequently you're going to have an excision. And if it's on the head and neck, the excision is going to be this term called Mohs surgery. And Mohs surgery is the combination of surgery, an excision, and the pathology to review the tumor that's been removed and confirm that all of the roots have been removed. The most common concern of patients regarding the day of surgery is the wait, the thought about the unknown, and the unknown duration for how long it's going to be between when the initial excision is done and that return of the pathology result is something that some people think a lot about. But if you start off with thinking about the day as a spa, it's more time with your book. Don't worry about what we're doing in the lab, and know that at the end of the day, we're going to go back until we have removed all elements of the tumor and make sure that this is something that doesn't bother you going forward. If you're having a simple excision, you don't have to wait for the path results to come back before we do the suturing closed, but you will still need to have the pathology report come out. Usually it's 4 to 10 days after your excision. Again, that wait is something that weighs on some of our patients, but please know that there are things that we can do if it does turn out to have deeper roots. Don't let the wait be something that you think too much about. And whatever you can do to focus on making it about you, find the things that you like, will make your day better. So this is an example of a patient who's had a tumor removed from his ear, and it's been subsequently reconstructed. And this is a good outcome for what we look to give our patients. There is some redness that I can see as a surgeon, but I bet most of the people at the grocery store or at your house of worship won't notice that this ear has a suture line on it that is still in its stages of maturing and disappearing. So to help you find the tumor or find the scar, circled in green, this is something that we, as your Mohs surgeon, as your dermatologist, our goal is to put all of the cosmetic subunits back into place. We're looking to make sure that you've got the function of all of the things that we're working on, and we're looking to make sure it's something that you, after a few weeks of healing, don't have any lingering thoughts or misgivings about your appearance and the function. If you do have anything that's still causing you some stress after 6 to 8 weeks, please reach out to us as your physician. There are things that we can do to make scars less noticeable if that's something that's concerning to you. And then finally, activities of daily living. Our recommendation is for people to rest. We don't want you to immobilize yourself entirely sitting in bed, but we do want people to take a few days off from playing golf, take a few days off from lifting weights. Light activity is always recommended. We want people to stay mobile and get around their house, walk their dog, continue to take care of themselves. But we don't want people to go and exert themselves by, lifting heavy weights at work or going swimming, things that might interfere with the healing of the wound. So it's most important for you to know that your surgical team is on call before your surgery. So if you have questions before, you can reach out to your surgeon. During the day of your surgery, at any point during your day of surgery, if there's something of discomfort, something that could be making your life better, please just let us know, because we're there to try to make you as comfortable as possible. And most importantly, in the post-operative period, if you have any concerns about maintaining your comfort, taking care of the wound, there's wound care instructions that will be provided for you at the day of surgery. You can use those to try to mitigate those concerns, to make your comfort better, or to take care of your dressing change better. And if those wound care instructions that you're given on the day of surgery aren't helping you, you can call your primary surgeon and have them give you some help and some feedback. And with that, I'm going to hand it back to Wesley.
Thanks so much, Dr. Carroll. It's really good to know that, even though that these are, these skin cancers can be serious, can require serious surgery, that process doesn't have to be scary, and that we put a lot of focus on giving patients the outcomes that they are hoping for. And so it's a process, but I love how you said your surgical team is there for you. All right. So we do have one question. We're gonna be answering questions at the end. Keep putting questions up there. We'll be answering them right after the presentations. Our next speaker is Dr. Christian Valenzuela. Dr. Valenzuela is a surgical oncologist here at OHSU and an assistant professor. He also co-leads our OHSU Melanoma Tumor Board, which does both melanoma and all other kinds of skin cancers. He specializes in treatment of high-risk skin cancers, melanoma, and sarcoma in particular. His lab focuses on examining the relationship between blood vessels, tissue development, and cancer development. I have the privilege of sharing patients frequently with Dr. Valenzuela and have immense respect for his surgical expertise. I'm really looking forward to hearing his presentation on new developments in our field. Dr. Valenzuela.
All right, I need to restart Zoom. Give me 10 seconds.
Oh, sure. No problem. We'll see you in just a sec. In the meantime, then we will answer this one question. So what do basal and squamous cell carcinomas look like if ignored? Dr. Zhang, Dr. Carroll, do either of you maybe want to take a stab at that?
I'm back.
Oh. Go ahead, Dr. Zhang. It looks like you might have a...
when basal cell and squamous cell skin cancers are ignored, they really just grow larger. So they're like larger versions of the photos that I'd shown before. And then sometimes they can start bleeding. They can often bleed on their own, and they just become pretty large, hard to ignore things.
Yeah. Yeah. So if you do let them grow, they can get pretty big. And, as we talked about before, you may need surgery. We can try to make that surgical experience as good as possible. But it is always good to get them early and get them when they're smaller. So that is when you need your general dermatologist and good dermatopathologist to make those diagnoses for you. Thanks, Dr. Zhang. All right, well, so we'll move on with Dr. Valenzuela. Thanks for presenting.
Pleasure to be here. Hi, everyone. My name is Christian Valenzuela. I'm one of the surgeons, one of the primary melanoma surgeons here. I've been here for about 1.5 years at OHSU, and the majority of my surgical practice is skin cancer and melanoma. So that does entail a fair share of non-melanoma skin cancers. That's what we'll talk about today. I have one disclosure. A close family member of mine, my father used to work at Regeneron as a scientist for many, many years. He's retired now. So I do have a very positive view of this company. I'll be talking about one of the drugs that they produce. I have no financial positions, nor have I in the past in this company. So this presentation is my opinion. My opinion only, does not represent the opinion or position of OHSU. All right, so with that aside, We'll first talk about non-melanoma skin cancers, prevalence and death rates. You already heard from Dr. Jang a little bit about that. We'll talk about sentinel lymph node biopsy technique, which is one of the techniques I do commonly for melanoma and oftentimes for non-melanoma cancers as well, skin cancers. We'll talk about the role in squamous cell, basal cell, and Merkel cell carcinoma. We'll talk about immunotherapy or programmed cell death 1 inhibition in squamous cell cancer. And we'll talk about the sonic hedgehog pathway inhibitors in basal cell cancer. These are relatively new drugs and treatments. So first, melanoma. Last estimate from the CDC from 2020 was 77,000 new cases per year in the US, with just over 8,000 deaths in that year. So about 8,000 deaths per year for melanoma. Non-melanoma skin cancers, that is basal cells and squamous cells, that number is harder to pin down because there's no separate statistics for them. Formally, the American Cancer Society estimates 5.4 million new cases in 3.3 million people over a year. And 80% of these are basal cell carcinomas, and roughly 2,000 to 8,000 deaths per year from combination basal cell and squamous cell. Merkel cell is a lot more rare, about 2,000 new cases per year in the nation, and 5-year overall survival is about 70%. And then there's a miscellaneous category, which we won't talk today, Kaposi sarcoma, cutaneous lymphoma, and adnexal tumors, but those are extremely rare. This is a visual representation of the skin cancers in new patients and deaths per year in the US. I don't have exact numbers here because these are, again, estimates, but the size of the circles are roughly proportional to the number of new patient diagnoses. So melanoma, 77,000 new patients with approximately 8,000 deaths per year. That's in orange. Basal cell and squamous cell combined, approximately 3.3 million patients with up to approximately 8,000 deaths per year. So the number of deaths from basal and squamous cell roughly is just shy or about the same as melanoma per year nationally, but the probability of death from basal and squamous cells is much smaller. In other words, much more common, but less dangerous to life. And Merkel cell is much more rare, with death rates on par with that of melanoma. So skin cancers like spreading in one of two ways: lymphatic through the lymph vessels to the lymph nodes, same system used for self-defense against viruses and bacteria, and hematogenous, or through the bloodstream, typically at later stages. Generally speaking, if skin cancers choose to spread, they prefer the lymphatic route first. So how can we detect when this is happening at the microscopic level before it shows up on a scan or physical exam? In this technique, the surgeon injects generally 2 tracers. There's a small amount of a radioactive tracer and a blue pigment around the site of the skin cancer. And then both tracers flow downstream the lymphatic vessels to the lymph nodes that would carry cancer if that cancer chooses to spread. So the lymph node biopsy, this isn't a cancer scan or a detection technique. It is a technique to select the appropriate lymph nodes that would drain that particular patch of skin. And those are sent to the laboratory. It's called a biopsy, but it's not a needle. It's an actual incision and a small operation to remove one or a small group of lymph nodes. They get sent to the lab. There's a little handheld Geiger counter in the OR that leads us to the right lymph node or nodes, and it actually turns blue with the blue pigment injected. Sent to the lab, and about a week later, you see under the microscope the result of whether there's cancer there or not. The most concerning risk of this procedure in the armpit or in the groin is lymphedema. That is a swelling of the limb that can be permanent. This can happen up to 5% of the time, so this procedure isn't risk-free. In melanoma, this is a standard part of the operation when the tumor has a thickness of 1 millimeter or taller or thicker, with some exceptions. I bring this technique up here because for non-melanoma cancers, the topic of today's talk, sentinel lymph node biopsy can sometimes be used as well. And as patients, it'll be important for you to know why it is sometimes recommended and sometimes not recommended. So the national guidelines for melanoma, the most updated ones are shown here, include offering sentinel lymph node biopsy for most, with few exceptions. There's a lot of evidence to support this, lots of controlled clinical trials, but that's not the topics of today's talk. For the squamous cell carcinoma, the current recommendation is to consider sentinel lymph node biopsy for high risk or very high risk cases that are potentially curable with treatment. That's not a strong recommendation, not as strong as for melanoma to offer it. And sentinel lymph node biopsy can be combined with Mohs operation or standard excision, traditional surgery, which is what I do. For low risk squamous cell cancers, there's an extremely low risk of metastatic spread, and thus the operative risks of sentinel lymph node biopsy are not worthwhile. What are the characteristics that define the three categories of squamous cell? Low, high, and very high risk. They're listed here. These are well-known characteristics clinically and under the microscope. So if you fit into the high risk or very high risk categories of squamous cell, then you'll want to talk to your surgeon or dermatologist about the possibility of sentinel lymph node biopsy. It's important to consider this before resectional operation or treatment of the cancer, because once the tumor is already operated on, that disrupts the lymphatic vessels and makes sentinel lymph node biopsy, the tracer technique, less likely to succeed if it's done after that resection. There's frankly not very strong evidence to support the use of sentinel lymph node biopsy in squamous cell, even for high-risk lesions. These are main results from a multinational Australian-led study from 2016, studying the outcomes after sentinel node biopsy for high-risk cutaneous squamous cells of the head and neck. This is observational, not prospective, only 57 patients, but there was a significant correlation between worse postoperative survival and positive sentinel lymph node result. But again, these were very small numbers in this study. Here is a similar Japanese multi-center retrospective study with 169 patients with squamous cell cancer of the skin with disease-specific survival shown here. No difference in survival. Those are the top two lines between sentinel node positive and negative results in cases without abnormal lymph nodes found on exam or physical exam, or on scans or exam. But if abnormally large or diseased lymph nodes are found on physical exam or on imaging, the survival becomes significantly worse, and sentinel node biopsy is typically not done. So, according to this study, the more important factor for survival is not the sentinel node biopsy result, but whether there are clinically detectable abnormal lymph nodes on exam before the operation. The bottom line is for high risk or very high risk squamous cells, sentinel lymph node biopsy is often done, but shouldn't automatically be done on everyone, since the evidence is kind of thin. It will be an individualized decision, a judgment call to look at the risks and benefits of the procedure for each patient. And with most cases, if you're at OHSU, will be discussed at our skin cancer tumor board as a group before coming to a final decision on sentinel node biopsy. By contrast, for basal cell carcinoma, although resectional surgery is the primary treatment, sentinel node biopsy is not recommended nor performed. Although national statistics group basals and squamous cells together, these two skin cancers behave very differently at the lymphatic level. Basal cells are extremely unlikely to metastasize, even the large high-risk ones. So sentinel node biopsy is not worth the operative risk of namely the lymphedema. So instead, the primary tumors are resected and the patient can undergo surveillance ultrasounds or CAT scans for high-risk lesions. To give you an idea, basal cell cancers happen millions and millions of times worldwide per year, but it has only been reported a few hundred times in the literature to metastasize. For Merkel cells, briefly, sentinel node is a standard part of the treatment because the proportion that do spread through the lymphatics is considerable, on par with that for melanoma. So what happens if a patient has metastatic or borderline resectable or unresectable squamous cell cancer? In the past, there were no good options, palliative radiation or palliative chemotherapy. In recent years, however, with the advent of immune checkpoint inhibitor therapy or immunotherapy, it's been a game changer in many cancers, skin cancer included. The most commonly used treatment we give for melanoma is Keytruda or pembrolizumab. For squamous cell cancer, there's FDA approval in 2018 for a similar immunotherapy drug called cemiplimab. Trade name is Libtayo. This is an intravenous medication given every 3 weeks. Early trial data showed a majority of patients had a partial or even complete regression of the tumors while on therapy. One published example is the top panel there, before and after 6 weeks of cemiplimab. This is squamous cell. And the bottom panel is a waterfall plot showing individual patients represented each by a bar, and those in the negative territory mean the tumors shrunk. There were 3 patients all the way on the right whose tumors completely went away during the trial period. This study should be interpreted with caution, however, because this did not study survival, whether the patients actually lived longer than those who did not receive the therapy. That data should be coming out in the next few years. The other non-chemotherapy option in advanced squamous cell carcinoma is pembrolizumab, also an injection every 3 weeks, which uses the same method of action and was also approved by the FDA for squamous cell cancer in 2020. The point of this is if you find yourself past the point of what we call curative intent surgery for squamous cell, there are still options and hope for you. These medications are not problem-free. They do have side effects and potential for serious adverse events, but they are options we didn't have for squamous cell just a few years ago. Let's talk about basal cell cancers. For these that are unresectable or locally advanced, there are also new medical therapies available that weren't available just a few years ago. Surgery is still first choice, but these are cases in which it's not possible to do surgery or radiation to achieve a cure. These medications are not used in small or easily resectable basal cell cancers. And the medications are called vismodegib, approved in 2012, and sonitigib, approved in 2015. These are pills. They work against the cell signaling pathway called sonic hedgehog. I'll explain the name in a minute. This cell signaling pathway is abnormally activated in basal cell cancers. In a phase 2 trial, neoadjuvant or preoperative vismodegib shrunk the tumors and allowed for smaller or less morbid operations in 71% of patients, but recurrence rates were high at 36%. So it's not a slam dunk or a cure, but probably helpful for selected patients. Another phase 2 trial, sonitigib, was given long-term for locally advanced and unresectable cases, led to 56% of patients having at least some shrinkage of their tumors over a long-term, nearly 4 years or 42 months. This drug was tolerated well by most, and roughly a third of patients having a serious adverse event, but no one dying from the medication. And cemiplimab is also a choice in basal cell carcinoma, got an FDA approval in 2021 for this indication. However, the first choice in basal cell is the hedgehog inhibitors. So in the 1990s, it was almost like a gold rush where labs around the world started being able to discover and reliably decode functional genes in humans and animals. And if you discovered a gene, you get to name it. So a genetics lab group at Harvard, led by Dr. Clifford Tabin, discovered a new gene within what was known at the time as the hedgehog family of genes, not because they were discovered using hedgehogs, but because knocking out the gene led to embryos of fruit flies looking spiky under the microscope like a microscopic hedgehog. So each new discovered member of this family of genes was named for a different hedgehog species, just kind of like a tongue-in-cheek sort of a joke. And a postdoc in Dr. Tabin's lab, Robert Riddle, named the gene they discovered Sonic because his daughter, a young daughter at the time, loved the character, the Sega character Sonic the Hedgehog. And then it turns out this gene happens to be one of the most important genes in the human genome and in animal development. And this pathway happens to be one of the main players also in basal cell carcinoma. And now Dr. Riddle is the head of neuroscience at NIH. So just as an aside. So basically, in conclusion, non-melanoma skin cancers, we went over the prevalence and death rates, newer treatment options in non-melanoma skin cancers, including the usage of sentinel lymph node biopsy and its role in squamous cell, basal cell, and Merkel cell carcinomas. checkpoint inhibition or PD-1 or immunotherapy treatment in squamous cell cancer, and the hedgehog pathway inhibition treatment in basal cell cancer. All right. Thank you so much for your attention. I appreciate the time, and thanks for the opportunity to speak.
Thanks so much, Dr. Valenzuela. That was a great overview of the systemic treatments and the surgical oncology treatments that might be needed when skin cancer gets advanced. And I think it also helps answer Peter's earlier question about what happens if you ignore a basal or squamous cell carcinoma. It sounds like those skin cancers can get big enough that you can't cut them out, and then you have to use systemic or other kinds of therapies. All right. And I love the Sonic Hedgehog. I remember playing a Sega Game Gear as a kid. All right. Well, so our next speaker, I already see a couple questions actually that he's going to be addressing. Dr. Sean DeMary is an associate professor and director of the high-risk skin cancer clinic at Massachusetts General Hospital, also known as MGH. He's a physician scientist who does both basic science and translational research in the area of cancer immunology related to melanoma and non-melanoma skin cancers. His lab is focused on determining how the immune system might prevent the early stages of cancer development, so preventing skin cancers before they start, and also treating them when there are a lot of them. He's the recipient of numerous research awards, including the American Academy of Dermatology Young Investigator Award and the NIH Director's Early Independence Award. I was really excited when Dr. DeMary agreed to join us today and look forward to hearing his thoughts on skin cancer prevention and immunology. Thank you for being here, Dr. DeMary.
Absolutely. Thank you for the invitation. And can you hear me and can you see the slides?
Yep,
Yes,
they're coming through. Great.
Thank you. So as was mentioned, I'll be basically talking a little bit in realms of research and understanding of therapeutics as it relates to non-melanoma skin cancers. And before I do that, I do want to spend at least a couple of minutes explaining when we talk about cancer prevention and use of the immune system, what we are really talking about. And this diagram, and before I go into that, I should definitely mention that I've been co-inventors on patents relating to topical immunotherapies for cancer prevention and therapy. So as I mentioned, what we are really talking about with cancer development is really depicted here in a very textbook version of the event, which is progression of a young and healthy organ like in skin over time, exposures to various environmental carcinogens and oncogenic viruses and so forth, leading to development of an aged organ, which is still perfectly functional and architecturally intact, like old skin. However, as we all know, we call those, for example, sun-damaged skin or old skin. They're more prone to development of cancer within them as we age. And similarly to that organ, the immune response and immune system within that organ also undergoes evolution as we age and changes from early young immune responses to a more developed and more experienced immune responses as we age. And many of these alterations in immune responses have been shown to be in response to pathogens and allergens that affect us as humans and as exposures to these environmental, if you will, insults. However, the question remains, which is what is the function and role of these immune responses in this transition from an, if you will, damaged organ to a cancer development within that organ. And clinically speaking about this axis, it's really the question of secondary prevention by the use of immune system. Can we really leverage the immune responses within the organ, namely in this case skin, to block this transition from intact tissue and intact organ to a cancer within that organ? So what we have done in this front has in different aspects of this over the years, but one of the areas that we have been really active in is use of agents. These are immune factors, they're called cytokines, to re-educate the immune response within the organ and try to promote this cancer suppressing benefit of immune system and prevent cancer development. Now, as we talk about non-melanoma skin cancers, this really relates back to the topical use of immunotherapies, novel immunotherapies, to enable this type of skin cancer prevention. This was beautifully explained already there. But when we talk about skin cancers, we mainly talk about keratinocyte carcinomas or squamous cell cancer and basal cell cancers. But also we do think about melanoma and other skin cancers as well. And because all of these skin cancer types could be amendable to a topical immunotherapy for their prevention of development and recurrence. Today I'll be just talking about the squamous cell carcinomas and the work we have done to hopefully showcase how one could really use the immune system in this front. And before I get to that, we would say that in the field of squamous cell cancer, we do have modalities that are aimed for prevention of the cancer. And these are mostly developed to target precancers to squamous cell carcinomas, and those are called actinic keratoses or AKs. The main modality, or one of the main modalities used in the clinic right now, are cryotherapy or freezing of those actinic keratoses when the patient presents to the dermatology, but also use of topical chemotherapy, like that is 5-fluorouracil, which is the most commonly used topical chemotherapy for this for elimination of precancers and hopefully prevention of squamous cell carcinoma. Likewise, we use another cytotoxic, or if you will, chemotherapy-like agent, which is both a chemical application and also light treatment afterwards to enable the killing of these tumor cells within the skin. And also the topical imiquimod, which is an innate immune activating agent that has been around for some time. So what we have done and what we really developed came out of fundamental research, looking at skin cancer development in experimental models, and then realizing that there's a novel immunotherapy that stems from this work that could help with the treatment and prevention of squamous cell carcinoma. I would not be talking about the experimental work that we have done, but what really emerged from that experimental and research in models was this understanding that a vitamin D analog, a low calcemic vitamin D analog called calcipotriene, these other names listed here on the slide as well, is a type of chemical that when it's applied topically to the skin can induce an immune factor. And that immune factor or cytokine is a very anti-cancer type of cytokine that could block cancer development in the skin. I should point out that this calcipotriene has been, prior to our discovery, been used for psoriasis, for treatment of psoriasis in patients, and really enabled this translation of what we have found into the clinic. So based on this discovery, we really wanted to understand, can we use this topical way of inducing immune factors to eliminate precancers and prevent cancer? And to do so, several years ago, we developed a trial looking at this question in immunocompetent patients using this topical agent calcipotriene, which induces the cytokine I mentioned, TSLP, and this induction of immune response then hypothesized to be augmented by the chemotherapy already being used in the clinic, and that's the 5-fluorouracil, to enable a potent immune response against these malignant cells within the skin. And we performed this study now several years back, and the results were very promising, demonstrating that this combination of the topical immune factor inducer and chemotherapy can be very effective in eliminating precancerous lesions, but also preventing development of squamous cell carcinoma up to 3 years after the treatment of these patients within this trial. And since that time, it has now been, this topical immunotherapy has been added to the national guidelines for the treatment of multiple precancers, patients who have multiple precancers in their skin. So I would like to emphasize from this type of work that the implementing effective immunotherapy to prevent skin cancer in high-risk patients may be instrumental for our ultimate goal of cancer prevention in patients. And what do we mean by high-risk patients when we talk about skin cancer? Patients who are high risk are patients who are at risk of developing new cancers. And these are, again, non-melanoma skin cancers, multiple of them over time. And there are several categories of these patients that we always see in the clinic, and we really would love to have a better preventive modality for them. And those are patients with history of 4 or more skin cancers in the past. If a person has 4 or more non-melanoma skin cancers in their history, they're almost 75% guaranteed to develop a new one within 2 years. Also, patients with immunosuppression, this was talked about prior, patients with genetic mutations that predisposes them to skin cancer, as well. And among these groups that I listed, the really severe and main group that we always see in our clinics are in patients with immunosuppression that develop especially squamous cell carcinomas. And immunosuppressed patients belong to several group of diseases. Some of them are acquired immunosuppression, and some are inherited in the genome and in the DNA of the patients. The cause of immunosuppression, again, organ transplantation is one of the primary causes of immunosuppression in patients. A disease called chronic lymphocytic leukemia is a very prominent cause of systemic immunosuppression as it relates to skin cancer risk and squamous cell carcinoma risk. Ulcerative colitis and other inflammatory diseases also can increase the risk due to the immunosuppressive medications that these patients receive. And HIV/AIDS, now this problem has been much less nowadays due to better treatments for AIDS and for HIV, but it has been a similar issue in context of skin cancer risk. And I would like to sort of bring up this last slide here as well, that we are now gearing up to enter this realm of bringing immunotherapy to folks who are immunosuppressed and can we see better efficacy and improved efficacy in these patient populations compared to the current treatments they're receiving with mostly chemotherapy-based approaches. And this is really has been a collective effort across several centers in the U.S., at our hospital at OHSU and the Washington University in St. Louis, and also University of Arizona, trying to understand and trying to test whether the topical immunotherapy that we have developed could be beneficial for kidney and lung transplant recipients in order to boost their immune response in their skin and hope that we can at least reduce the rate of skin cancers these folks develop over time. And I should mention that this is obviously sponsored by NIH, the NCI, National Cancer Institute, Division of Cancer Prevention. And that's with that, I just want to close by saying that we do propose that immunotherapy can really revolutionize how we think about cancer prevention, similarly to how it has really proven to be revolutionary in context of cancer therapy. And thank you. That's my last slide. Thank you.
Thank you so much, Dr. Demary. That's really wonderful to see the whole progression from early basic science published in the 2000s all the way now to super exciting clinical trials in such a high need area, for transplant patients who we see get so many of these skin cancers. And, I think it goes directly to a lot of patients' questions. I mean, Susan here asked the question about whether some of these creams can treat skin cancer or keep it at bay. And, I think your lab and the work you've done has shown that, yes, I mean, using the immune system with those creams can actually prevent some of these skin cancers. And so we're excited to be a part of that trial. And I'd encourage anybody who's listening, if you have a transplant and have had skin cancers, this is a great trial to participate in. So we've heard today from our panelists everything from diagnosis of skin cancers to surgical treatment to systemic treatments. We heard about tumor boards, the kind of discussion you might get at a major academic center like MGH, OHSU, or Case Western. And we've also talked about how you might be able to prevent these skin cancers from happening if you are somebody who is getting a lot of them. We still have a little bit of time for questions. If anybody would like to post any others, we've answered some of them in the Q&A screen. And so if you have any other ones, please feel free to post them there. We'll give everybody just a couple minutes to see if there are any other questions. I think Peter posted a question on where on the body you can get these kinds of skin cancers. So Peter's question was specifically about squamous cell carcinomas, but this is really true for almost all skin cancers. Skin cancer often is caused by sun exposure. That UV radiation from the sun breaks up the DNA in cells and can make them become cancers. And so, you can find these skin cancers most commonly on places where you're getting that sun exposure. So the head and neck, hands, feet, maybe the lower legs if you're in shorts a lot. But you can find them anywhere. And so it is important to get in with your dermatologist if you're concerned about a spot and see, get an exam if it's something that's concerning you. I see a question from Patricia. What are your thoughts on image-guided SRT for treatment of basal cell carcinoma? And I'll just say image-guided SRT is a type of radiation therapy. Dr. Carroll, if you're on, is that something that you might want to talk a little bit about?
So superficial radiation is something that has two camps in the radiation oncology world. Radiation oncologists are an integral part of our tumor board for tumors that go perineural or go to places that we can't easily get to surgically. The image-guided superficial radiation is also an intervention that has been recently marketed to dermatologists who are not necessarily radiation oncologists. And it doesn't have the same cure rates that we have with surgery. And there's also some advertising for it that might be a little bit aggressive. It's something that I do not routinely offer to my patients for primary therapy, so as the first-line therapy. And the radiation that we do use in tumor board tends to be the electron beam or the harder radiation that's being used to go after the more aggressive and deeper tumors.
Thank you. That's really helpful. And so it sounds like this superficial radiation therapy is not something that most centers are currently using. Is that right?
Most tertiary care centers are not using it. Something that's more offered in some of the private practice clinics, and it is an expensive treatment when offered appropriately for the superficial tumors that it might treat. And as far as its ability to treat deeper tumors, the superficial radiation is not what you want to use for cancers that have dermal involvement or deeper involvement. So in our practice as a tertiary referral center, we see a lot of things that are partially treated by radiation that then come for definitive therapy a year or two after, as the tumor resurfaces later and doesn't have the clearance rates that you can get with surgery.
Thank you. So yeah, it sounds like it might not treat something that's a little bit deeper, and you might not necessarily know it's deeper before you start treatment. So yeah, that's something that's good to know. Thanks, Patricia, for the question. Okay, so we have a couple of other questions. There was a question from a Facebook user, an anonymous attendee. Did I understand that if you have a lot of skin cancers, you could qualify for a trial? I'm currently using compound creams and I'm nervous that the spots are already basal cell. So, I mean, I think it depends on what kind of skin cancers you're getting and what your background is. But certainly, I think, if you go to your the university that's close by, they may have a trial for you. Dr. DeMary, is this something that, you would encourage being at an academic center? Is this something that might be available?
Yeah, so sorry, it's a great question. I'm not aware of the trials now open in terms for patients who have had multiple skin cancers in the past for cream treatment or for topical treatments. What I was referring to was the trial for the organ transplant recipients that have systemic immunosuppression and trying to help them with cancer prevention as they're at the really the highest risk of developing more severe form of the disease. But hopefully in future there would be again more opportunities as those of us who think about this field start to translate some of our discoveries into the clinic.
Super exciting. Yeah. Thank you, Dr. DeMary. And I see just a comment from Jim Bryan, who had a basal cell carcinoma that went to the bones, currently being treated by cemiplimab, stable, and have had several rounds of radiation. Yeah, Jim, we're all with you and hope for the best. Sounds like you're doing well. Yeah, this is the kind of thing that we we treat all the time, and really wishing you the best. I think we have a few closing comments from Anne from AIM at Melanoma, and so I think we'll hand it off to her now. Thank you, everybody, for attending, and thank you to our wonderful panelists.
Well, thank you, Dr. Yu. Yes, I appreciate this opportunity to talk just a minute more about AIM at Skin Cancer, our foundation, and our new website. Our web, we're seeking to support the community. Our web pages are rightly so dedicated to prevention and education, and that's because we believe that well-informed patients are able, to make better choices for their care, and we hope, therefore, have better outcomes. We've built a website with information on all facets of skin cancer, and that includes diagnosis, staging, treatment options, and even side effect management. But there are some other sections I'd like to make sure that everyone is aware of. The first thing is a new image library with 50 photographs, including several on people of color. We wanted to make it as comprehensive as possible because we know that it's important to show the variety of ways, that skin cancer can present on the skin. And we also have a section for caregivers. Caregivers are important, and they, will often offer advice to their loved ones on the care that they receive. So we want them to know how to best support their loved ones. We have a service that's called Ask a Skin Cancer Nurse. That's a free and confidential way to ask questions from a nurse who's been treating skin cancer for 30 years. This is not in an effort to change your plan of care, but just to make sure that you understand what your care team is suggesting or offering to you. And then finally, we have a media library. Included in that is a number of webinars featuring expert guests from all across the country and these educational symposiums. Tonight's symposium will be edited and then divided by topic, and we'll place it back onto our website so that you can watch these presentations as often as you would like, or invite members of your family to watch them so they can better understand your treatment. And with that, I'll just say thank you to Dr. Yu. Thank you to our panelists for just fantastic presentations this evening. And I want to wish everyone a wonderful evening. Thank you for joining us this evening.